Good morning, Chris Ohl, Wake Forest School of Medicine, Infectious Diseases, with a periodic COVID update. Because I know lots come out in the last 3 weeks or so, some things to talk about and update people on, and we'll see where we're at with our cases. So right now, as of yesterday afternoon, we're sitting here in Forsyth County at 43 per 100,000 per day. And that's higher than it was. I think the last time we talked was 3 weeks ago. So cases are going up, but they're going up slowly and not as exponentially or quickly as it did with Delta or Omicron or really any of our previous waves. So that's good news. Actually, if you look at other areas in the state, it's more the urban areas. So Mecklenburg County is sitting at 39 per 100,000 per day, so not much different. And Wake County has got the lead right now in the 70s. So compared to Omicron, where we had a lot more of the rural counties around us having more cases than the urban for a while, it seems to be a little bit reversed now. And why are we seeing more cases? I think the simple reason and the main reason is that people are out and about doing things and being more socially active and having more get-togethers, and everyone's back in school still, and a lot of end-of-year parties, graduations, big concerts, things like that. So I guess it's a bit to be expected. Looking at our case numbers and then also at the sewer data from the Charlotte area and then up here as well, it looks like things are plateauing out some. So I don't really expect a major surge to come out of this right now. Perhaps later in the summer, but not for the next few weeks. That doesn't mean that people shouldn't still be taking precautions, and so you're just going to have to choose your own risk and precautions that you want to do. And we've talked a lot about that over the last few months, but if you have elderly, vulnerable people at home, and you want to go out and do things, you might want a mask. Good N95 is going to protect you, or a KN95 will protect you, even if people around you have COVID. And if you have a big get-together you need to go to, like a wedding or something, you might want to be careful for the week or two before that. If you're giving away, you're the father of the bride, you might want to chill for a while because you don't want to get COVID before going, because that's going to keep you from going if it's in your 5 to 7 day isolation period. And it also means you want to have some tests at home. So if you get a runny nose or allergy symptoms or cold-like symptoms, so that you can test for COVID. So if you know you have it. Interestingly, we have a lot of cold viruses going around right now, including still influenza is still being transmitted, at least up here in the Triad area. I assume it is in other areas in the state too, which is really late because usually our flu season's over by the end of March. And so COVID, I guess, delayed onset of flu and the flu going away. So we are having cases of good old influenza still mixed in there with some of the COVID. Fortunately, this variant that we're seeing here, which is the BA2 variant, and a small number of the BA1.12.1, I think are the way the numbers go, are no more severe than Omicron was. In fact, it may even be a little bit less severe. At least that's my opinion. Looking at the latest case data and waves and the amount of hospitalizations and deaths we've been having. So consequentially, while our hospitalizations are up some in the state, including here in the Triad, it's nowhere near what it was in January or February. In fact, it's not even a fifth of what it was at the beginning of February. So, and here in Forsyth County, I was talking to Joshua Swift, our tireless health director this morning. We've had only one death in the last 3 to 4 weeks in Forsyth County, so it's all real good news. The other big thing in the news for us is that last week boosters were approved for 5 to 11-year-olds, and that would be Pfizer's vaccine, and it'll be the same vaccine that they got as the initial series. So the kids who've gotten vaccinated so far, which in that age group I think is roughly at about 50 to 60% of that age group has gotten their first 2 shots, are now eligible to get their 3rd shot because they got it in the last part of October. You want to wait 5 months. 5 months is up, so it's time to think about vaccinating as a booster. So let's go through whether or not you as a parent want to think about having your 5 and 11-year-old boosted. And there's a little bit, you have some decision-making process to go through. First of all, it is true that kids in that age group who get COVID usually get a milder infection, and it's unusual for them to get a multi-system inflammatory disorder or get hospitalized or have a severe infection. And so that's good, actually, but it's not 100%. So there are some kids who will get more severe infection and end up hospitalized. In fact, during Omicron surge back in January and February, the highest numbers of kids hospitalized since COVID started is what we saw. And some of that has to do with increased transmissibility and the fact that the kids were out there doing things like being in school and playing sports and play groups and so on and so forth, but they are still doing that. So if you want to avoid the small chance of severe COVID, then go get your child boosted. Unfortunately, just 2 shots, it looks like, in the age from 5 to 11 is not all that protective for Omicron. In fact, it's probably only somewhere between 15 to 30% protective for a breakthrough infection. While it's likely it's protective for severe infection or hospitalization, we don't really know. There weren't enough people who got hospitalized in the study to know. So 3 shots are going to tank up the immunity and make it much less likely that your child will have a breakthrough infection in the near future. Some people have asked me, well, should I get the booster now for my child, or should I wait until this fall before the winter season? And you have to sort of ask yourself a few questions that really only you can answer. If your child has any kind of underlying illness, then I would go get boosted now. That's kind of a no-brainer. So diabetes, asthma, lung disease, cystic fibrosis, or is immunocompromised or taking immunocompromised medicine, then they go get boosted now. In fact, immunocompromised people should be, even the 5 to 12-year-olds, 5 to 11-year-olds should be getting their fourth dose now. If you are going out of the country for your travels in this summer, you might want to consider having your child boosted, because a breakthrough infection in England will mean that you'll be spending some time watching The View in your hotel room in London rather than coming home right away, because if you get a positive test while traveling, you can't re-enter the United States for 10 days until your isolation period's over. And so that's disruptive. So if you're planning international travel, that would be a reason to get boosted, because even a breakthrough will be disruptive. If you have a busy summer and you're going away to sleepaway camp for 2 to 4 weeks, and your child's going to be there, you probably don't want to be getting a phone call saying you need to come pick your child up because they've got COVID now. So most camps are actually requiring vaccination. A lot of them don't stipulate whether they need to be boosted or not. But I think if you're going away to a sleepaway camp, a child should be boosted this summer. Otherwise, I guess it's okay to wait until the fall. I think children in that age group will, in the fall, will still be getting the current vaccine. Now, Moderna may be getting their vaccine approved for this age group as well, sometime in June. So if you want, you could wait until June and do the Moderna vaccine as the booster. And the first 2 would have been Pfizer, and then do Moderna as a booster. Theoretically, it might provide a little bit more robust and long-lasting immunity by doing that. So there's another wrinkle to think about. But I think that, it really should have been a 3-shot series all the time. We didn't know that when we first rolled it out. So 3 shots are really what it's going to take to have a complete series for COVID vaccination in that age group, just like it is for adults. So vaccine approval process is moving forward for kids under the age of 5, both Moderna's vaccine and Pfizer's vaccine. I think that the meetings will be in the middle of June. So by the end of June, vaccine will be out and available. We are and will be giving booster shots for 5 to 11-year-olds right now in the Atrium Health Wake Forest Baptist system. You can schedule your appointment by calling 336-70-COVID, 336-70-COVID, or go to your My Wake Health account and schedule your booster for your 5 to 11-year-olds. Currently also the health department is boosting kids now. So you can go to the health department. I would probably get online with them and make an appointment to do that. And you can get your child boosted there. I'm sure that the Novant system and other health systems in our area are also doing so. So it doesn't really matter where you go, but I think it's wise to get your 5 or 11-year-old boosted. And I certainly plan to be doing my 8-year-old in the next week or 2. So how are our schools doing? Well, the private schools get out Friday. That's tomorrow. Happy end of school year for our private schools in the area. Our public schools got a couple more weeks yet. So there have been some clusters in some of the public schools, not only here but also in the state. And the contact tracing is a little bit less robust than what it had been a year ago because for a lot of reasons. It's a lot harder to do with the Omicron variant. Plus it's with the ability for children to mask and get vaccinated now, and the fact that the variants aren't quite as severe, it doesn't quite have the urgency it did before. So what the schools do now is they give you a letter saying that there's been a cluster of cases in an area. Now, each individual school can see what's going on in their school, and you can take local measures for one school if it makes sense to you. For instance, if you have 7 or 8 cases in a second grade, and it's within one second grade, you can mask the second grade for 10 days. And you don't have to do it forever. Just do it while the cases counts up. And then that takes the risk of in-school transmission away. And so local principals and teachers can work with the health department and make those decisions to do that. We've had good success with some of the private schools in the area. with limited short-term masking. In fact, one time we only did it for a week, and that was it. And boom, that was the end of it. Same thing in some of our local universities. So it's an approach you can do. Treatment, we're still the best treatment out there for COVID is Paxlovid. Who should get treatment are people who have mild to moderate illness, who are outpatients, who have underlying health problems or are older. And you can call your doctor or talk to your doctor about that. No need to pop into an emergency department. Urgent care is fine, but you can see and find out ahead of time whether or not it makes sense for you to get treated, because not everyone needs it. If you're otherwise healthy and under the age of 60 or so, you probably don't need to be treated. That will save more drug for the people who do, it'll also save you some angst, because the study shows that younger, healthier people don't really benefit from it as much as people with underlying health problems or older people. For older people and people with underlying health problems, it's really a big deal, because it's 80% reduction in hospitalizations in that group. So there's been a couple interesting things about Paxlovid. One is that there's a lot of drug-drug interactions, so if you're on other medicines, you need to let your doctor know that if they don't already. So if you get a script called in, that it doesn't interfere with the medicine you're already taking. One of the ones that that a lot of people are on are cholesterol medicines. And so if you're taking a medicine to lower your cholesterol and you're going to go on Paxlovid, you have to stop the cholesterol medicine while you're on Paxlovid, which, since it's a 5-day course, it's not a long time to stop it. It's not really going to affect your cholesterol to be off for just 5 days. The other thing is that occasionally we see in people who've had vaccination and boosters, in particularly rebounds of COVID. So the way that works, you get COVID, you're feeling kind of lousy, you take Paxlovid, and then you feel a lot better, you test negative, and then 2 or 3 days later your symptoms come back and you do a test and it's positive again. It rebounded. Why is that happening? We're not 100% sure yet. It may be that the Paxlovid course of 5 days isn't quite long enough. It could have something to do, particularly in people who've been vaccinated or previously had COVID, about immunologic responses and your own immune system, and not kicking in for the full duration because you got some Paxlovid as treatment in it. So there's a lot of theories, but we're not exactly sure. What we do know is that it does seem to be more common in people who've been vaccinated, and it also seems to be a little bit more common in people who are otherwise healthy, who really probably didn't need to be on Paxlovid to begin with, but for whatever reason they were. And that includes healthy older people. So what do you do if that happens? Well, if you get symptoms again of COVID after taking Paxlovid, what you should do is test again. Home test is fine. If that's negative, then I'd wear a mask until your symptoms are gone, but you can go around about your business. If that test is positive, then you have to stay in isolation again for 5 days. So you have to reset your isolation time, which, if you remember now, is 5 days of isolation. And then after that 5 days is up, you put out a mask and you come for the next 5 days. So it's a total of 10 days of masking and 5 days of staying home. Fortunately, the symptom duration in these rebounds tends to be short, 2 to 3 days, and not as severe. So hopefully it won't be too disruptive for those people. A lot coming out in the news lately about long COVID, and if it's confusing to you, feel better, because it's confusing to me. Every study seems to say something different, and there are reasons for that. One is that the definition for long COVID is so broad that it's really, we're studying a lot of different things, I think. So some aspects of long COVID are actually permanent organ system damage from the initial COVID that a person got. So you got COVID pneumonia, spent a few days in the hospital, and then you have reduced lung function afterwards because there was some loss of lung tissue with that. That happens with potentially can happen with every viral pneumonia, particularly more severe viral pneumonia. And it can happen after bacterial pneumonia. If you get hospitalized, bad pneumonia, most of the time you're going to have a little loss of lung function afterwards. You may not even know it. But since we're interested in studying long COVID now, a lot of people are getting studied who've had COVID, and we measure this. It could also mean that people who had pre-existing kidney disease, getting COVID tipped them over needing dialysis. Is that long COVID, or is that just the kidneys took a hit from COVID? So it's kind of how you define it. And then there's the more, prolonged fatigue, feelings of weakness, mental fogginess, things that are difficult to measure and see. And some people call that long COVID, and that tends to be harder to study and a little bit harder to know. So because of all of that, the studies show that the incidence of having long COVID after COVID is somewhere between 3% and 80%. So that's quite a range. So I think we need to hone in a little bit, and when you look at the studies, say, who did they actually look at? What group, who were they? What symptoms were they looking at? And what did they mean about long COVID? So, but I think overall, I think that probably 20 to 30% of people have some type of sequelae of having had COVID. And some of it's minor, they may not even know it. And some of it can be more severe. It does seem like people do have more of a propensity to get blood clots for up to a year after having COVID. A lot of discussion on whether or not only severe COVID causes these problems. I think as far as the organ system, damage, so if you had COVID pneumonia and got lung tissue damage, that's more common in people who've got severe COVID and got hospitalized, particularly if you were in an ICU. But some of the other more difficult to define symptoms may also come up from people who have less severe COVID. In fact, one study even showed that maybe people who get it asymptomatically can get long COVID. But that's based on serosurveys. And but I think that for the most part, more severe COVID is more likely to cause sequelae than less severe COVID. A lot of debate on how much vaccination protects you from long COVID. I think from severe consequences of long COVID that you might get from being hospitalized, since vaccination keeps you from being hospitalized or having more severe COVID, is going to be less common if you've been vaccinated, and I think the studies show that, particularly in Europe. But some of the more harder to define symptoms like fatigue, headache, mental fogginess, it's a little less clear how much vaccination might help with that. I think we're finally figuring out that if you have long COVID and then you get vaccinated, it doesn't impact so much on long COVID. But if you got vaccinated beforehand, at least some of the studies show that you're less likely to get long COVID. I think that's what the predominance of the science is going to end up showing in the long run. So a few other things in the news. Monkeypox. I thought it was refreshing to be able to talk and look about something different for a while. What is monkeypox? Monkeypox is an orthopox virus, and an orthopox virus includes smallpox and cowpox and monkeypox. It does not include chickenpox, which is a herpes virus. It originally, where we see monkeypox is in West Africa or Western Central Africa, like the Congo. And the reservoir for it are small mammals and monkeys. And sometimes monkeypox enters into the human population, and it can be transmitted from human to human. The variety of monkeypox that's been going around the world, mostly Europe and North America, but other countries as well, is the variety that comes from West Africa, which fortunately isn't as severe. In fact, less than 1% of people will die from getting monkeypox. And it's usually people who have underlying health problems. Can be transmitted from person to person, but it's not as contagious as smallpox. And you have to have pretty close contact with somebody to get it from them. And the closer contact you have, the more likely you might be able to get it from them. So you really need to be within 3 feet of them for a long period of time, or actually touching that other person. And where we're seeing the outbreak occurring right now is particularly with men who have sex with men, and probably with their sexual intimacy that they're having. And so obviously that's close contact. And so it's not something you're going to get from walking by somebody in a grocery store or sitting next to somebody in church. You have to have that pretty close, intimate contact. But for public health, we have to be able to diagnose and respond fairly quickly to these cases if and when they occur. And we have had none in the triad, by the way. In fact, I don't think we've had any in North Carolina. But if a case should occur, we get to find the contacts of that person through contact tracing. And then we vaccinate them. And we vaccinate them with a pox vaccine that has activity against smallpox and monkeypox. And that prevents them from getting it after exposure. So it's kind of like, it's a little bit different. Like we get vaccinated with COVID vaccine to prevent from getting COVID or to make it less severe when we get it. This is more like rabies vaccine, where you get bit and then you go get your rabies vaccine, and that keeps you from getting rabies. So if you've been in contact with somebody with monkeypox, you're vaccinated. I don't think you have to worry about it. If you have, whether or not you've been in contact with somebody, you're probably going to know it, or somebody will come and tell you through contact tracing. But the lesions of monkeypox can look a little bit like herpes and a little bit like syphilis. So we do have to do some testing in healthcare for those other diseases as well. But so in summary, I really don't think that the population at large really needs to be too worried about monkeypox. We as doctors need to know what to do, but the population at large doesn't. The other thing that's been going around is we've been seeing some cases of severe hepatitis in children over the last few months. Still not 100% certain what it is, but it looks like what it is adenovirus number 41. And other adenoviruses are known to cause hepatitis, so it certainly is biologically plausible. And when we see severe hepatitis in kids, we test for that, and there's a large study going on through the CDC now with that. Unfortunately, adenovirus 41 is not treatable, and the usual things we use for hepatitis don't he doesn't respond to these drugs. So the care is supportive. Fortunately, it's very rare. It's very unusual, and we've had none of these cases here in the Triad, to my best of my knowledge. So so that's kind of where we are with COVID and other things. Are there any questions from the group here? Are we? No? So everyone have a safe and happy Memorial Day. When we come back on June 9th, I'm going to throw in some stuff about staying healthy during the summer. So ticks and swimming-associated infections and things like that, since summertime is just around the corner.